Okay. Well, happy Friday, everyone. Brandon Gare with the National Minority Equality Forum. It's Friday at noon, at least noon on the East Coast. And, on these Fridays, we like to edutain and just talk about some health issues that are happening that are impacting our community. This one you've probably heard a bit about, but you're going to hear a little bit more: closing the coverage gap, ensuring access to obesity care for health and safety. I was going to say our very own, but Christina Epperson, who works with us a lot. It's her homecoming week. She's a Wolverine and a Bison, so it's her Bison homecoming weekend this weekend. But she leads policy at the National Medical Association, which is the largest. I guess they're the originally health equity group. They've been working on it since for over 125 years now. She happens to lead their policy team right now, and she's going to lead the discussion today. So I'm going to turn it over to Christina to get us started.
Thanks, Brandon, and thanks for always mentioning I'm a Bison first. Howard homecoming is always going to be top of mind, but great to see everybody on this Friday afternoon. Thank you so much for being here with us to talk about such an important topic. Obesity coverage is something that the National Medical Association has written statements about, has participated in, Hill visits on, and advocacy efforts. And so it's a pleasure to be able to moderate a discussion to talk about such an important topic with such an elite group of panelists who I will be introducing right now. First, we have Mr. Kevin Stevens. Then we have Dr. Ray Serrano. Then we have Mr. Mark B. Johnson. And finally, we have Ms. Nancy Glick. And I'm going to give them the opportunity to kind of give us a quick overview of their how they show up in this space. And then we'll go into some robust discussion followed by Q&A from the audience. So please make sure to put questions in the chat, questions in the Q&A box. And we hope to be able to get to all of them as we talk about obesity coverage and its importance in the United States. So Mr. Stevens, would you mind kicking us off with a little brief overview of what you do and why this issue is important to you?
Yeah, thank you. Thank you for inviting me to this conversation. I'm a human services manager here in Riverside, California, and I've been a person living with obesity all my life. I've struggled with my weight all my life. I went to my first Weight Watchers meeting when I was in the 4th grade. And all my life, throughout my childhood, they told me he'll grow out of it, he'll get taller, he'll play sports and all this stuff, and he'll lose the weight. But that never happened. So I was yo-yo dieting throughout the years. And then I finally, the comorbidities related to my obesity made me start thinking that I needed to do something. I developed sleep apnea, high blood pressure, things like that. And then I really got nervous and scared when I was diagnosed with lymphedema because my legs were swollen. I finally found a doctor, because although the doctors was blaming everything on my weight, I finally found a doctor that was very honest with me. He told me the lymphedema could be because of your weight, but we don't know. So I'm not going to say that. But he did guide me and recommended the gastric bypass surgery, which I had in 2011, which I was successful. I lost 220 pounds. During that time, I became a member of the Obesity Action Coalition, and I became a patient advocate for patients. I learned how to advocate for myself, and I learned how to advocate for others. That's to give other people a voice on how to navigate through the physicians and the doctors and things like that. And my advocacy really helped me when fast forward last year, about a year and a half ago, I started regaining a little weight. I successfully lost 120 pounds, but I never did reach my goal weight. And I ended up gaining back for about 45 pounds. So I went to my physician to talk about the new GLP-1s. And the conversation did not go well. He said, "You're not diabetic." And I explained to him, "I'm pre-diabetic. This would help me from not becoming diabetic." He said, "No, I don't prescribe it, only to my diabetic patients." I said, "Well, what about the alternative drug that's marketed for weight loss?" And he said, "No, you'll have to go through the weight loss center again." And then he finally told me, he said, "Kev, you already did the easy way before. You just need to stop eating as much and exercise more." So, like I said, the conversation didn't go well. Just long story short, I switched physicians. I have an excellent doctor now. He was able to get me on to a GLP-1 drug, which I've been very successful with. But I had obstacles with that drug as well, because you have to go through certain criteria and meet a certain BMI, which I did at the time. But I was denied 2 or 3 times, 3 times actually. And really was the navigation, because of what I do on a daily basis in my job. I deal with appeals. Customers have to appeal their benefits and things like that. I kind of know how to navigate, but most people don't know how to do all that. And they get discouraged, and they might just stop and quit. And I was lucky. I was able to navigate through it and get approved. And I've been successful for the last year on my GLP-1. But with the OAC, the advocacy that I do for them, we go up to Capitol Hill. I've been up to Capitol Hill twice in Washington, D.C., to talk to the lawmakers about the Treatment to Reduce Obesity Act, is to get Medicare to be able to, for Medicare, recipients will be able to have GLP-1s and other weight loss alternatives available for them, along with behavioral health, because behavioral health is a part of it as well. Right now, those are covered under Medicare. Medicare is a gold standard of the insurance companies. Once Medicare approves something, usually all the other insurance companies will follow through. So, in a nutshell, that's basically my story in regards to my advocacy, what led me there, my weight loss journey, and now my new GLP-1 journey. And I just like to educate people. That's what we do with the OAC. We educate, we advocate, and we help with biases and stigma with the obesity, for people living with obesity.
Thank you so much. I'm going to pass it over to Dr. Ray Serrano.
Yeah, so sorry, can you hear me? So yeah, my background is in kind of health economics and health services research, and I kind of stepped into this space for obesity. It's kind of deeply personal for me. I think my mom, I always talk about her, kind of single mom, and she worked two jobs. Every day, I just remember she would leave the house around 6:30 in the morning to start working in the fields. She worked in agriculture. We grew up in Idaho. And then she would work 8 hours there, come back home, shower, and then start her evening shift at the local potato processing plant. So a total of 16 hours every single day. By the time she was in her late 50s, she had her weight was just getting out of control. And she got to the largest, it was 535 pounds. By the time she died at the age of 73, she had lost a lot of weight. Unfortunately, it was right before GLP-1s came out. But we all started thinking about like kind of my mom's mother and my mom's grandmother. Mom's grandmother lived up to 102. Mom's mother lived up to 109. But mom died at 73. And we thought how crazy that is to think that my mom's grandmother, my mom's mother, who were born in Mexico, raised in Mexico, lived in a village with no running water and electricity, could live up so long. But mom, who was born in the U.S., raised in the U.S., dies 35 years less. And so I thought something changed here. And to think of that, also my mom, the ladies that she worked with at the potato plant, she outlived most of those ladies. Most of those ladies died in their late 50s. So again, this is a huge community. When you look at the statistics, 50% of Black and Latino, and mostly women, are obese. 50% of our adults are obese, and it favors more women than men in the adult population. For youth, it favors more boys than girls. It's 30% of Latino youth are obese, around 30%, so about 27%. GLP-1s, when they went on the market, were really a game changer, a real game changer for many of us. But unfortunately, they were out of reach. If you look at the uninsured population of the U.S. and you lined up every uninsured person, 4 out of 10 would be Latino. So in the entire population of the U.S., 1 in 6 Latinos are uninsured. And so again, uninsured, underinsured usually doesn't have access to this. And so having Medicare and having Medicaid cover it has been a big fight. A lot of states have been fortunate to cover it. And in more recent years, and really this past year, a lot of states have been cutting back on it. You see Connecticut, you see Pennsylvania, California, and a lot of states have just refused to cover it. And then there's a treat and reduce obesity act at the federal level, which has been something that we've been pushing hard on. And again, we try to educate a lot of our educators. It's not so much the story of what action to take, because people get kind of sticker shocked and think it's going to cost too much. But we also try to highlight the cost of inaction. There is a cost. And the cost might not be to the government workers, but it comes to cost of the family. For me, we lost mom, right? We lost a parent. But also mom, by the time she died, she had everything. As Mr. Stevens mentioned, she had sleep apnea. She had the total knee replacement. She had diabetes, hypertension, you name it, everything, congestive heart failure, all of it, because obesity unlocks the key. It unlocks the door for 206 diseases. And mom had about quite a few of those. It wasn't 206, but it was a lot of them. And she became really kind of $1 million patient. She became a lady who worked for minimum wage, but really costing the system probably about $1 million just to keep her to back some sense of normalcy. And again, what we're trying to fight for is to have that access to those treatments, those life-saving treatments. But also, in addition to that, to all the whole continuum of care. It's not, you don't go into fight a fire with saying, okay, you can only use this fire hose. You can only use this type of fire truck. You want to use all the equipment available to put things out. And that's exactly what we're asking for. And it's been a big fight to do that. But I think part of the fight is the indifference and the refusal for folks to see this as the real disease. As Mr. Stevens mentioned, this is like, people struggle with this. My mom struggled with her whole life. I struggle with myself. Like a lot of us struggle with this because it's not willpower. You try to do as much, but there's genetics, there's predisposition, there's the environment that we live in. And that all plays into the factors of why certain communities are that way. If it was strictly willpower, we wouldn't see the disparities between Black and Latino and the white population. We wouldn't see the difference between income levels. But we see this quite often. In many ways, I say that one of the biggest ingredients in this kind of crisis or epidemic for obesity has been powerlessness. And it's been powerlessness, the systemic powerlessness that we have as a community, but also there's also genetic innate predisposition for it. But I think the real power that we all have is to really recognize obesity has been a disease labeled by the American Medical Association since 2013. So it's been 12 years. And not only that, it has destroyed entire communities. Like I said, my mom, we used to go to the company picnic. All those ladies we met at the company picnic when I was a kid, they're all dead. And they're all dead. They all died in their 60s, late 50s, and early 70s. That is crazy to think that entire population has been wiped out. So again, I stress we come in from that standpoint. So a lot of the work that we do at the League of United Latin American Citizens, we're kind of very old. We've been founded in 1929. We do a lot of kind of healthcare awareness to try to incubate the next generation of healthcare advocates. So trying to get folks to speak out about this issue, to remind folks that it is a disease, to remind folks that there is a cost in action, and to really kind of speak out at all levels. So we have councils in about 40 states. We have local LULAC councils. And so and that is kind of the backbone of our organization. So we do a lot of the work locally in different states and different communities, but reminding them that this chronic disease is a very, very serious disease, and it takes some serious measures to really combat it. So,
Thank you so much. You brought up a lot of great points that I know that we'll revisit later on the conversation. Mr. Johnson, if you could also give us about a 3-minute overview of your work in this space.
Thank you, Christina, and good afternoon, everyone. Thank you for having me. It's great to be here with my fellow panelists to talk about an issue that affects millions of Americans. As we kind of talked about already, obesity is a complex chronic condition influenced by everything from biology to social determinants to the environment. And today, more than 100 million adult Americans live with obesity, along with 1 in 5 children. And some states have, higher obesity rates than the national average. And obviously, to what Ray was alluding to, there are certain racial and ethnic groups that are disproportionately affected. And beyond the human impact, the financial cost of obesity is staggering. About $173 billion each year in obesity-related medical expenses. And, we also know that obesity is linked to 200 comorbidities, but none more closely than diabetes, which is why the American Diabetes Association is deeply engaged in this conversation. And in recent years, anti-obesity medications, especially the GLP-1s, have changed the game, and they offer an effective non-surgical treatment option for people living with both diabetes and obesity. But there's a catch, and it's that these drugs, are expensive, and many people can't afford them. And even those with private insurance still face high costs. And Medicare only covers them when prescribed for diabetes and not for obesity. So that's where the Treat and Reduce Obesity Act, often known as TROA, comes into play. And this is a widely popular bipartisan bicameral bill which would allow Medicare to cover anti-obesity medications and related treatments. It made some real progress last Congress, passing out of committee for the first time, but unfortunately it didn't reach the finish line before the session ended. And so executive branch action was taken by the Biden administration to cover the cost of GLP-1s, which was canceled earlier this year by the current administration. But groups are continuing to lobby the Trump administration to change their view on that on this particular issue. And so ADA will continue to push Congress and the administration to expand access to these life-changing and in many cases life-saving treatments. So thank you again for including me in this important discussion, and I'm looking forward to today's conversation.
Thank you. And last but not least, Ms. Glick.
Last but not least, well, I want to start by mentioning what Kevin said, that he was lucky to be able to get care. It is the position of the National Consumers League, and I know also OAC, that you shouldn't have to be lucky to get access to therapies that significantly reduce the burden of obesity and chronic disease. In 2024, the National Consumers League and the National Council on Aging, working with a number of stakeholders, issued the first Obesity Bill of Rights for the nation. We did so because we believe, and we want everybody to support us in this, that every person with obesity deserves to have quality obesity care. Obesity is the #1 chronic disease, dwarfs all the others in terms of prevalence. 100 million adult Americans are living with the disease. And as my colleagues have said, they're stigmatized. Many go to health professionals like Kevin did, who disregard obesity and consider him the problem. And we have a healthcare system that throughout considers obesity less than diabetes and cancer and osteoarthritis and sleep apnea and 230 other chronic diseases. And so people with obesity do not get parity in terms of getting quality treatment. And one of the most important reasons for that is because they do not get access to the treatments that are part of a medical treatment guidelines from numerous medical societies. Not having access, not having coverage may save on a state budget. Or we're now learning that a number of federal agencies, from the Veterans Administration to the Department of Defense, agencies that had covered obesity through their health plans are now cutting back, again, cost being the issue. What happens is, and I think Kevin brought this up, is that and so did Ray, Obesity costs the nation significantly in medical expenditures for these other diseases. And so short-sightedness and budget balancing really is just, in the long term, setting our nation back. There's another cost that I want to bring up, and that is that people who do not get coverage for obesity, and let me just add that if you do have diabetes or some of these other conditions where Medicare will cover and Medicaid will cover and commercial insurers will cover, you might have a $25 copay for a GLP-1. If you do not have coverage at all, you have to figure out what to do. And many, many people these days are now going to an unregulated online marketplace where they are getting unapproved drugs, untested, and many of them are facing harm. They are being subject to counterfeits, and there are a number of fakes. So this has now become an issue of fraud. It has become an issue where a lot of people are opting to choose things that if they had coverage, they would go to a doctor, they would be diagnosed, they would get the proper treatment, and they would be able to maintain the treatment regimen and be successful. So the cost of not covering is much greater than just saving money. It is people's lives, and it is preventing significant fraud. So all of us on this call today need to really unite around the fact that, yes, obesity, treating obesity is a right. And we need to make sure that people are able to achieve that right.
Thank you so much. I think all four of you really gave us a lot of great points that we can dive deeper into. I think we could all talk about this conversation for much longer than just the hour that we have. But I would love to start with, it seems like everybody is in agreement that obesity is the cause of a lot of other comorbidities that individuals have. But it feels as though obesity is not as taken as seriously as a disease as if somebody says, I have diabetes, or I have high blood pressure, or any other myriad of diseases that they may have. If somebody says that they have that they are obese, it is not taken as seriously as a disease. So I wanted to ask you all, and this is a question for anybody in the group that would like to answer in 2 to 3 minutes. What role does stigma and outdated perceptions of obesity play in the limitations of policy progress to get coverage for the disease?
Well, I'd be glad to start with that because we address this in the Obesity Bill of Rights. Unfortunately, obesity is a stigmatized disease, and there is significant weight bias. There's data on how significant weight bias is, and it's system-wide. So health professionals have weight bias. Insurers have weight bias. And I think many of us who've gone up on Capitol Hill to talk about TROA notice that policymakers have weight bias. So it is a significant challenge. I constantly talk about the fact that, if the AMA recognize that obesity is a distinct chronic disease, and pretty much every other medical society followed in a consensus about that, it's time to stop this idea that this is not a serious disease that we should pay for and blame others. But it really is a significant issue, and I think we have to address it both with people like Kevin and with all the data we have that shows that this is really a serious chronic disease.
And Kevin, I'd love to hear from you as a representative from the National Medical Association who represents Black physicians. And you said in your own story that your physician, you had to go to a different physician because your original physician was not really believing in what you were saying and was just saying, you just need to lose weight, like as if it's not that hard. What role can physicians play, or how can we as advocates approach physicians to better be able to empower and represent their patients in this space?
For the physicians, I believe they need more training on obesity to really learn what the disease, that it is a disease, to accept that it is a disease, and get educated on that. They have to get more information on that so they'll know how to deal with their patients that have obesity. My primary doctor, which I had for years, he's the one that he recommended the gastric bypass surgery for me in 2011. And then fast forward to 2024, he's telling me, oh, his whole how can I put it, demeanor changed. And the conversation was very different when I went to ask about the GLP-1 drugs. And he says, oh, I don't do that, only if you have diabetes. I said, well, what about the other drug that's marketed for just weight loss? No, I don't prescribe that. And what I tell people, you have to find a physician that will give you options when you're dealing with any type of weight loss journey. You have to be given options. You have to find someone that's going to tell you the different paths that you can go, and you work with that physician to go on that right path. But if they're closed-minded and they don't want to do it, it's very difficult. In the medical community, I've noticed that, for example, I had to have an MRI when I was at my heaviest. I hurt my knee, so I went to an MRI, and they looked at me. They were looking at me strange, and I go, I need to schedule an MRI. Well, we don't think you're going to fit into the MRI machine, and I wouldn't at that time. I wouldn't. I was 420 pounds. I wasn't going to fit in that machine. And I said, okay, well, what do you do then? Well, you have to have an open MRI where it's on a table and they do it where you're not inside of a enclosed space. And I said, okay, but they made me feel like it was my fault. And I heard them in the background, the nurses and scheduling people talking, oh, we have to try to find an open MRI and da 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 da. And I'm saying, I'm right here. I can hear you guys, So things like that is things that I had to deal with in my lifetime, living with obesity, and it's just very it's getting better. It's getting better, but it still needs a lot of work. And I think and then you have the issues with the insurance companies. They put you through a lot of you got to go through a lot of hoops sometimes to get approved for the GLP. I know I had to go through it just because my doctor didn't put a date on there or something, a start date, because they made me take a class. I was required to take a class for 6 months. And I understand all that. There's you have to do what you have to do. So I did the class. And just because my doctor didn't put that I'm still enrolled or something minor, they wouldn't approve the pre-authorization. And every 6 months I have to be pre-authorized. I have to get a reauthorization. And it's not always a smooth ride when I have to do that. I've been, like I said earlier, lucky. Actually, I'm blessed that I've been able to go through these hurdles and to get my medication. But a lot of people don't have that opportunity to do that.
Yeah, I think one thing that I really like that you said is you have to find the physician that's going to work for you. And I think a lot of patients often feel either silenced because they don't feel like, okay, well, the doctor knows best, so maybe I should just kind of take a back seat. Or they feel like, well, I've been going to this doctor for the past 20 years. They wouldn't lead me astray. And it's not always the fact that the doctor is trying to work in your worst interest. That may not be it at all, but I think we all come with natural biases that we may not even realize. And so it's important to say, if I'm not getting the care that I want to receive, if I feel like I'm not being heard and listened to, there is no shame in exploring other options when it comes to seeing a doctor, because there are thousands, hundreds of thousands of physicians in the country that would be happy to see you if the person that you're currently seeing is not able to give you the treatment that you need. Now, when we talk about legislation, I know Mr. Johnson and Dr. Serrano, both of you have experience on, one on state more so and on federal, and the other on federal more so. And this is a state and a federal issue. So I want to know what specific legislative or regulatory actions could meaningfully expand access to evidence-based obesity treatment, including GLP-1 therapies.
Can I was going to touch upon the
Right.
previous point.
Oh,
My
sure.
So my first step into kind of public health was through HIV. And I worked a lot, and I worked overseas on issues of HIV. And I was working with the World Health Organization at the time when they test to treat policies were becoming a thing. So you like in Thailand where I was working at, they would wait till your CD4 count was at 200 and below for you to be started on treatment. It was basically 200 and below for CD4 counts full blown AIDS. So basically, you had to have AIDS in order for you to get antiretroviral treatments. And so the studies were showing that you start people early on treatment, and you can actually reduce their viral load. You can load shedding, and you can basically have that as a form of prevention. Well, the idea of doing that, there was pushback from the community itself, saying, "Well, you're trying to medicalize this disease." And there was also pushback from the policymakers because it's going to cost too much money. And we were trying to show them that there's a cost to inaction, there's a cost to action. I think of HIV, you don't think normally as obesity and HIV being kind of similar, but the stigma on both is very severe. The questions always on HIV is, how did you get it? Clearly, must have done some bad behaviors there, right? And obesity is the same thing. How did you get it? Clearly, you were reckless in your behavior. And then always this idea of why should we pay for what people would consider reckless behavior? And so there's this value statement, right? That the folks who have obesity or who have HIV almost need to be punished by society for having that, in which case, and their punishment is going to be apathy and indifference. And so that's what we're seeing. And so now we're trying to fight to merely recognize this disease as a disease that is the medical community has all long recognized that it's been that way. So it's been a tough fight in that front. And then for these life-saving medications and for this the continuity of care to get everybody on board is a huge fight. It is a huge way of thinking of things in a different way. So I think, I mean, the stigma is a huge factor in all this because you really have to stress to folks that like there's not really very much choice that folks have. That sometimes you would think that like it's I mean there's a biological component, a genetic component to it, but there's also like like an environmental component to it. And when you think of folks like who are on say on SNAP benefits who are getting $2 less than $2 a meal, $6 a day. I mean, like, what can you really buy with $6? A Subway sandwich down the street from me is $6.75. That's the cheapest one for 6 inch. I mean, that you can't, and that's your whole meal for the whole day, and you can't even use your food stamps to buy that. So I mean, again, there's not very much choice, and the question of what physicians can do, quite often, folks like Kevin, folks like myself, it's rare for us to be in those spaces, to be in front of policymakers and speak to them. The stigma prevents a lot of folks from wanting to do it, and then also the cost of just being advocates on it is another cost. But clinicians can do that. They see these patients, they know their stories. They can communicate those stories without revealing the names of the patients and say, my patients in this clinic have this experience, and this is why I'm here to speak to you. That's where I think there needs to be. My sister is an OBGYN, and I always talk to her about it. And she's like, well, I don't do politics. So I'm like, girl, you got to step it up because like you're living in a political world, whether you like it or not. You have to step it up. Like, and politics is not it's going to come to you either way. So if you really care about your patients, you're going to care about the political health of your patients as well. And so I have to throw that out there. Anyways, one of the things we do at the state level is that idea of trying to incubate that next generation of just noisemakers, healthy noisemakers, right? To be agitators for good, and to go into those Medicaid commissions, to go into to speak to their state legislators, to find out, and sometimes they don't make it easy because you have 60 people testifying on a certain bill, and they won't tell you what number you're at, and you got to wait all day long to testify on that bill, 4 hours long. And so should you write a letter, you want to follow it up, but it might be easier, but sometimes in person really does matter too. But I can say in these last year, we've been losing a lot of coverage. States that there was an upward trend for states covering GLP-1s, but we're seeing the big one was California. We're seeing states, and the states that were kind of tipping their toes into thinking about doing it, Oregon, trying to get for the state health employee benefits. Maryland was thinking about doing it. Now they're not even thinking about it anymore. And that's really unfortunate because I think there's a lot of folks that are missing out. And again, the urgency, as Nancy mentioned, folks are so desperate for some relief that if they're not getting it through coverage and getting the actual meds, They're going to the bootleg market. They're going to that dark area. For Latinos, we go to the border, and there's a lot of fake drugs flooding the border. And we go through these local bodegas that they sell fake GLP-1s, Ozempic patches. There's no such thing as Ozempic patches, but they're selling them. And then they have people who are on Ozempic promoting them on social media saying, I lost 60 pounds. Yeah, dude, you lost 60 pounds on Ozempic, but you didn't lose it on your little Ozempic patch that you're trying to sell to our people. And that misinformation is flooding our market so badly. But again, people are turning to it not because they want to be in that nice zoo or go to the beach. They're doing it just for simple relief. They just want to survive.
Thank you so much for that. I love girl, you got to step it up because politics touches all of us, whether we realize it or not. And so it's really important that all of us, in the words of the late, great John Lewis, cause some good trouble, because even if it doesn't affect you directly, then it affects somebody around you. And so that's why we have to be in community in order to combat these issues. And Mark, I'd love to hear from you about, like I asked before, what legislative or regulatory actions we can take, especially on a federal level. I know we've all briefly talked about TROA in this conversation, but how we can do that for evidence-based treatment, because as Ray just said, and as I will talk about a little bit in a couple of minutes, there is a lot of misinformation going around, as well as a lot of drugs that are not regulated that people are using, which is definitely what we do not want. So what are your thoughts on that, what we can do legislatively?
Sure. I'll actually start with the last question that you mentioned. There hasn't been much legislatively that has spoken to the compounding and counterfeit drugs. There are champions in Congress who are petitioning the current administration and the FDA to have tighter regulatory control and oversight of these medications, because they are a scourge. I mean, we don't know about the long-term, health cost with these medications. They come from unsavory sources and unregulated countries. They're not vetted by the FDA, and we don't even know about the efficacy of it. I mean, the efficacy is questionable. So far, the legislators are, pushing forth on the executive branch to do things. Legislatively, nothing has happened yet, but I think that's going to change soon. With regards to TROA, you know, I've had probably over 100 meetings with congressional offices on TROA. And, to what Nancy was saying earlier, policymakers have this bias and the stigmas that are associated with it. The two main things that legislators say is, they do the personal responsibility claim. What are you doing? It's your fault. Or it's, are you eating enough? Are you exercising enough? And they don't understand the complex nature of obesity. And then obviously the cost comes into play. Not realizing that initial investment, it's going to be high. But over time, being that obesity affects so many other diseases, it's going to bring those costs down and actually take the stress off of entitlement programs such as Medicare. I would say the saving grace is that there's generational stigma, and there's many members of Congress who are older, but some of the younger members of Congress, and this has been based on my experience, the younger members of Congress and the young staffers who we mainly talk to, they get it. They understand it. They know that it's not just personal responsibility or someone trying to get into a swimsuit for the summer, that it's really a complex disease that affects so many people. um, you know, the stigmas and biases that go into the medical community that Kevin alluded to. I mean, doctors get very little training, only maybe one class dealing with nutrition and obesity. And they're not also able, as far as like what we say, the bedside manner. They don't understand the mental and psychological effects that come with having obesity. So it's a matter of just getting the medical community, the policy community together, And what usually seals the deal, and Kevin can speak to this, and this is one of the parts of my job that I love, when we have Hill meetings and we bring just ordinary patients, us lobbyists, we think we're cool because we speak all this legislative speak, but it's the patients. They are what I call the closers. They're the ones that share the personal stories and how it affects their lives. And that kind of cuts through all the nonsense and about the numbers and which committees and all that other political stuff. So we need more of the advocates to reach out to their congressional offices, continue to talk about this issue, continue to talk about just how it affects your everyday life, that it's not just about personal responsibility. To what Ray was saying, there's socioeconomic factors that come into play, genetic factors, environmental factors that come into play. So we need you all to, for the advocates out there, the families, to call your members of Congress, your senators, and your representatives, and ask them for passage of TROA, which is a game changer and will save lives.
I am one of my favorite sayings whenever people ask me about advocacy is that facts tell, but stories sell. And so, it's fine for us to go in and say all of the data and the information and have our little leave behinds and tell them how this could help them in their districts and blah, 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 blah. But what's going to drive it home are the people, as you said, Mark, like Kevin, that can say, my doctor didn't believe me. And that, put a strain on my life. And, I've been at Weight Watchers. I went to my first meeting since I was 14. Those are the stories that are going to stand with those legislators and going to allow them to be like, okay, I don't remember the numbers that they said, but I do remember the story that that person told. So I think I just wanted to emphasize how important that is. Nancy, I know in your initial conversation, when you introduced yourself, you talked about the risk that we take with patients possibly using other means. So I want to talk a little bit more about what those risks are with patient. What risks do patients face, when turning to counterfeit or unregulated GLP-1s because of lack of coverage, and how can that also incite more of an economic burden as opposed to just having it covered and being able to avoid those costs?
I'm happy to answer that. I do want to say one thing first,
Sure.
though, because there is some important good news. Studies are now coming out that are showing that if you treat people with obesity, the overall medical expenditures for a person on a health plan go down significantly. And a group called ICER, which is a outside organization that examines the effectiveness of a drug in terms of whether or not it's cost effective, gave a very high score to obese GLP-1s, which shocked us because ICER usually does not do that. So there's new data out there that we're talking about that shows that these are new drugs, and therefore it's taking time to be able to prove what legislators want to hear, which is that there is a cost savings. And so we're talking about that. But now let me, Christina, get to what you mentioned. So it's a little challenging for some, but let me just explain that a compounded drug is intended usually as a one-of-a-kind drug if a person can't take the branded drug for some reason. Let's say you're a cancer patient, you have difficulty swallowing, and you need a liquid as opposed to a pill, or you have an allergy. Compounded pharmacists will, with a prescription from your doctor, modify the drug so you can take it and it works for you. It's a wonderful thing. And none of us complain about that kind of use of compounded drugs. The challenge is when there is a shortage, which occurred between 2022 and 2024 for these obesity drugs, these GLP-1s. Compounded drugs are used to fill the supply chain. And because they're regulated differently, they're one of a kind. So there's no need for a label. There's no need to tell you what the risks are. There's no need to even track adverse events. We created this marketplace where telehealth companies, med spas, others are promoting drugs without telling you at all that there are risks. FDA has tried by issuing a number of statements to tell people that there's risk, but let's be honest, not all of us are checking to see what FDA has to say. And so what we've got here are drugs that are different. And because they're different, the active ingredient called API or active pharmaceutical ingredient are different than the branded drugs. They tend to come from India and China. As Mark said, they're not necessarily reviewed and approved, even, just as being this, not having good quality. But because they are different, the dosage levels are different. And so one of the things that we are seeing is that people who are taking these, and remember, these are injectables right now, they are tending to inject sometimes 10 and 20 times the recommended, the actual dose of the branded drug. That can cause serious harm. So FDA has been calculating the number of adverse event reports it's received. And it talks about harm from these medical errors, as they call it, from contaminants, from bacteria, and all of these things, obviously put people at risk. Poison control centers saw a 1,500% increase in calls from medical errors, people taking too much of these drugs. And then there's another thing, and this really keeps us up at night. There are bad actors now online who are selling this API, which is basically comes in a bag. And they are selling it online to people with a recipe for how you in your own house can make your own GLP-1 and inject it in your body. Now we know that that is dangerous. So at this point, we don't even know the extent of the problem because FDA was basically just looking at the adverse events that were reported to them. But there is a significant number. Many people were hospitalized, and there have been some deaths. So NCL and others, Ray, were all sounding the alarm to let people know that these are not benign and they're not the same, even though marketers right now are telling you they're the same. And it's a very big challenge for us. There has been some good news. The FDA has stepped up recently, and we will congratulate them for doing so. They have now decided that instead of just waiting for adverse event reports to come in, that they're going to go and start doing the job and trying to determine themselves, how serious these problems are. There was a large number of warning letters that went out in early September or mid-September to some of these companies, basically telling them they needed to cease and desist with their deceptive advertising. And FDA has implemented something called a green list now, which is an attempt to at least try to catalog this API that has come in, that has been reviewed, and that is safe. So it's a start, but it's just a start. And this is, Ray and I will both call this a cesspool online of things that people have access to. And we're not anywhere near at the point yet where we have gotten even a handle on it.
Yeah, it's good to hear that there is some progress, but clearly, as you stated, there needs to be a lot more to get where we need to be, especially in terms of patient safety, which I think is everybody's main priority. We have about 10 minutes left, so I want to make sure that we get to some of our answers from our audience. We also
Could I
have,
just
I'm sorry?
could I just add one quick thing to that last point? Like, so for Latinos, I think we have, I call it the trifecta or the perfect storm of for these compounded. And so you have obviously high burden of disease, right? 50% adult population is obese, 30% of kids. And then you have high rates of underinsured or uninsured folks. And that's the second part of it. And the third part of it, for Latinos specifically, I think is that I kind of pejoratively say like we're sponges for misinformation and disinformation. And what I mean by that is that because our biggest source of information for Latino communities is often social media, it's YouTube, it's Facebook. And if you look at the platforms on these, like, and we know this from COVID, and we know this from a lot of the election studies, a lot of the fact checking apparatuses they have in these software platforms are built for English speakers. So if I say COVID vaccine gives you cancer, it's flagged 85% of the times as misinformation. But if I say la vacuna de COVID te puede dar cáncer, it's the exact same thing in Spanish. 85% of the time it gets through. And so what we're seeing is a lot of deliberately predatory targeting of Latino communities. And then you have influencers who are on Ozempic and they're telling folks, I lost 60 pounds on this Ozempic patch, which doesn't exist. They don't say Ozempic, but this GLP-1 patch, which doesn't exist and it's not effective. And they're selling basically fake medicines. They're supposedly compounded, but they're not really compounded. They're actually sometimes they're flat out counterfeit. And they are so desperate for relief, they're turning to this. And they see this influencer who's lost weight, right? He lost it on actual Ozempic. But and so again, that is a big problem. So what we're seeing that has been a huge part of it. And the National Poison Center from 2019 to 2023, 2023, 2024, saw an increase of almost 1,500% of cases. And half of those cases were Black and Latino, mostly women. So again, this is an issue that falls squarely in our communities where we're being the victims of predatory targeting of these compounded medicines that are actively harming our community.
Thank you for adding that. I want to make sure, like I said, to get to a couple of our audience questions. So I'm going to transition us to that. We have a question from someone asking, from a parent's perspective, what policy changes are needed to close the gap in obesity coverage and make sure prevention starts young, not after the damage is done?
Well, I would say with regards to prevention, that would probably be something that's more suited for a provider to talk about. But from a policy perspective, again, I would just encourage everybody with regards to TROA, for example, to call their member of Congress and ask them to support the bill. That is very important. I know some people believe that members of Congress or politicians in general don't listen to their constituents, but they really do. They track each call, they track the letters, and they make the recommendations to their members of Congress. So in the House version of TROA, the bill number is HR 4231, and the Senate version of TROA is S 1973. Call 202-224-3121, ask to be transferred to your member of Congress, and then ask them to support those bills. And it really, really makes a difference. During the last Congress, like I said, we got to the committee, they passed a modified version of the bill, and it went to the floor, but didn't get to action. Each year, there's more co-sponsors to the bill, so we're making headway in areas of policy, but we still need to continue to get your voices, your stories to members of Congress and to support this important legislation.
Thank you, Mark. And to piggyback off that, he gave the number of the bills. If you just go on congress.gov, you can also type those numbers in and you can actually track the bill yourself to see where it is, if it's what committee it may be in, if it's in the House, if it's in the Senate. And on congress.gov, you can also find who your congressperson is, because I know a lot of us may not even know who's up there representing us. So that's the first step, is finding out who are the people, that are representing you in your district. Bray, someone had a question for you specifically, saying blessings to your ancestors and may their souls be at peace. What do you think, despite working long hours, was the cause for your mother's unhealthy weight and struggle with weight control? And I guess my question would be, how can we use that answer to be able to help empower other people who may be experiencing the same thing with their parents?
So I think, I mean, and going to the previous point as well, I think one of the challenges we face is, so in public health, you talk about upstream factors, right? How upstream can you go? The ultimate upstream factor is that we have communities that where everyone has access to healthy spaces, right? A healthy food environment, healthy parks, healthy communities. That is what we ultimately would love, right? And so I'm a huge fan. I've seen in other countries where it was worked, health impact assessments. So whenever you're going to build a new neighborhood, it has to, where's the parks, where's the, what are the number of fast food restaurants, what is going to be the impact on health? Anytime we build something into our spaces, at the heart of it is, what is that impact on health? Just like environmental impact assessments that the EPA does, hopefully it still does, on what is the impact on the environment. We have that on health. In the cases for folks, working class folks, it's super tough. It is super tough. I mean, even if you're on food stamps, which my mom, I don't really remember she was. I remember we went to food banks, and it was a lot of like starchy foods. There was a lot of sodium products. It was canned foods. And you did what you could, right? You just had to put food to fill the belly, right? You just had to go through day by day by day. You didn't really quite think about what you put in your body, because we're really just trying to, like, not, like I say in Spanish, pasar hambre. We're not trying to, be hungry, and make sure your kids are not hungry. And that is really the Herculean effort of the day, right? To make sure that they're eating something healthy, and you're thinking 10 years from now. Moreover, you also know that you're predisposed in certain spaces. You see it in your family, you see it in your ancestry, that having folks who are overweight, having folks that are obese, it's a part of you. And so it is a huge challenge to do that. But like, I think part of it is like, we can change it on the up end, but we can also walk and chew gum at the same time. We can try to change up those systemic things. But we also need relief now, because again, to lose somebody 35 years less than what they should have died at, it shouldn't be that way. And we're seeing life expectancy lower for certain generations and for certain communities. We're seeing folks, this obesity really is, I think in many ways, is the key for what we're seeing. It's that key for a door for so many bad diseases to come through. And I think if we can, and if we can make sure that, like, we keep that door locked permanently, we can really reduce a lot of the burden of disease in our community. But again, we could do that upstream, but as we try to fight upstream on those environmental and kind of justice aspects of things, we also need to look downstream of what is the here and now, because folks need relief right now.
Absolutely. I also want to note that there is someone putting some great links in the chat to some of the things that we're talking about. So hopefully the team will be able to send some of that information out following the conversation. And I'm also hopeful that there will be some additional information for the questions that we didn't get to answer as we're coming up on time, that maybe can be disseminated later. But I want to make sure to thank our panelists for such a great discussion. I think, as I said in the beginning, we could have talked about this all day. But I see Brandon back up on the screen, so I'm sure he's about to nudge me off. But I wanted to just first say my appreciation for the panelists and all the work that you do in this space.
No.
Thank you.
Well, thank you, Christina. Yeah, I wasn't nudging you off. I was just getting but as you said, we are getting into the hour, and I just want to thank everybody. Thank you especially for helping us put this together, and serving as a good, thoughtful moderator, and all our panelists for giving us just this great information. I'm remiss, I got contacted by Ajwa on our team, and we were working on something similar at NMQF, looking at GLP-1s and these sort of knockoff brands and how impactful it could be. And so if you look at, maybe it's one of the links I was talking about, healthnothype.org, something to check out as well. And I don't know if the panelists want to put their organization information in the chat, keep it open just a little bit longer, just in case someone would like to reach out to you.
And also, Mark, would you mind putting the bill numbers in the chat as well for the audience to have?
Yeah, good idea.
Yeah.
All right.
Yeah.
And so with that, we thank you. We hope you have a great weekend. Appreciate you spending this last hour with us, and hopefully you can, just continue to not only advocate for your community, but advocate for yourselves, especially in this space. So everyone have a good weekend.
Thank you.
Thanks. And